Thank you. Good afternoon, doctors. A warm welcome to this webinar on the role of Oseltamivir in flu management. This program is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare journey began in 1993 with 30 years of excellence and 36 state-of-art manufacturing facility. Hetero Healthcare has 300 plus products in portfolio and presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. Hetero Healthcare has Asia's largest API manufacturing facility at SEZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Hetero Healthcare pioneers in quality and innovation, and we have a distinction of bringing 4 biosimilar products to market within 5 years of initiation. During COVID-19 pandemic era, Hetero Healthcare as the pioneer in antiviral offered Oseltamivir, Favipiravir, and Remdesivir to the patients, for which they received an award of Pharma Excellence in August 2020 for COVID drugs. Today's webinar, role of Oseltamivir in flu management. We have got moderator Dr. Prakash Vaidya and speakers Dr. Mukesh Sanklecha and Dr. Anil M. Welcome, doctors.
Thank you.
Dr. Prakash Vaidya, sir, as we know, is MD/DCH, Diploma in Pediatric Sleep Medicine from University of Colorado. Attached to Fortis Hospital, Mumbai and Child Health Clinic, Mumbai. Sir is senior pediatrician with special interest in pediatric pulmonology. Joint National Convener, Asthma Training Module, Revision 21-22. Co-convener and writing committee member of Under 5 Visas Module of IIP. Writing committee member of Writing and Microbial Responsibility of Module of IIP. National trainer for IIP, NTEP, TB module, NRC cuff module, etc. Sir has many presentations at faculty at IIP and other platform, and past president of Thane IIP. Dr. Mukesh Sanklecha, sir, is consulting pediatrician, but Bombay Hospital Institute of Medical Science, Saifi Hospital, Mumbai, and has been in practice for past 30 years. Specialties include pediatric allergies, pediatric asthma, pediatric infectious disease, and teachings. Sir has more than 45 publications in index Indian and national journals, international journals, and has been faculty in a large number of national and international conferences. Welcome, Dr. Mukesh. Dr. Anil M.U., sir, is MBBS MD in Pediatrics, followed by, fellowship in Pediatric Critical Care, DA, Diploma in Allergy and Asthma. Dr. Anil is lead consultant pediatrics and pediatric critical care in Spurs Hospital, Bengaluru. Welcome, Dr. Anil. And with this brief introduction, I hand over the session to Dr. Prakash Vaidya. Over to you, sir. I'll stop sharing.
Yeah. Am I audible and visible?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Thank you very much, Dr. Prashant, for that introduction, and a warm welcome to my co-faculty, Dr. Mukesh and Dr. Anil. So without much ado, we will start our discussion. I'll first take a few minutes with some foundation facts, just a quick revision of something we already know. And I'll be talking in very short about something about the flu virus, the clinical picture of influenza, and followed by Oseltamivir. And having done the foundation facts, we'll straight away go into a number of case series which will bring out the role of Oseltamivir in flu. So we all know that influenza is widespread and seasonal epidemics are estimated are year after year. Almost 1 billion cases are there annually, and out of which 3 to 5 million are very severe cases, and they result in almost 300,000 to 600,000 deaths per year. Something about the virus. Now, this virus is a single-stranded RNA virus. There are 4 types of flu viruses, A, B, C, and D. The types A and B, they cause annual epidemics, whereas type A also causes pandemics. C is less common disease with fewer symptoms, and D is only seen in cattle. So the important viruses for our discussion are A and B. A is further subclassified into depending on the proteins on the surface. So there may be neuraminidase and there is hemagglutinin. So influenza A viruses infect a large number of species, and as I said, there are 2 structural proteins. One is the Na protein or neuraminidase, and the other is matrix protein is hemagglutinin. And these are the ones that distinguish the viruses from each other. Hemagglutinin and neuraminidase HA is a lectin that mediates binding of the virus to the target cells, whereas neuraminidase prevents the release or helps in the release of virus from the infected cells. So these proteins are the targets for our antiviral drugs. So as of March 24, influenza A virus in humans are of two subtypes, A H1N1 and A H3N2. B are not classified into subtypes, but B are actually B viruses are belonging to the B Yamaguchi lineage or the Victoria lineages. So there are two lineages for the B virus, Yamagata and Victoria, and influenza A, there are two H1N1 and H3N2. Now, a quick summary of the symptoms of flu. Flu is like any other viral syndrome, fever, headache, myalgia, cough, rhinitis. Only thing is that the symptoms tend to be much more severe in flu as opposed, and this is a generalized multi-site disease causing headache, nasopharyngeal symptoms, fever, respiratory symptoms, intestinal symptoms, joints, and muscular. So it is a milder version. A cold is a milder version of flu. Flu is a severe version of the typical cold. But then, of course, severity is subjective. A quick talk on antiviral drugs before we get down to the cases. So antiviral drugs are, one is adamantane. These are not important any longer because there is widespread resistance and these are no longer used. What we use today are the neuraminidase inhibitors, and this is, among them is Oseltamivir. Plus, there are other drugs which are also used like favipiravir, which is an RNAP inhibitor, and baloxavir. Now, baloxavir is not available in India. Which are the available antivirals in our country? This list is only given for completion. None of them except Oseltamivir is available today. But intravenous peramivir and inhaled zanimivir and lanamivir are also there, but may be available in our country shortly. But today, Oseltamivir is the most widely studied. And baloxavir is in the process of being approved, but not yet approved. So oseltamivir goes back a very long way, almost 26 years back. It was first approved for medicinal use in the US in 1999, and it is the first neuraminidase inhibitor available. It is a selective inhibitor of this enzyme, neuraminidase, which prevents the influenza A and B virus from replicating. It does not allow the virus to replicate and get into the cell and thus stops the disease in its tracks. The mechanism is it prevents the release of virions so that new viral particles are not produced and the disease stops. So with this short introduction, I'm now going to go for some cases and I'll request my panelists to give me their answers so that we can learn a lot in this next few minutes. So let's take case one. This is a 2-year-old boy with high-grade fever, cough. Initially, he was interfebrile active, but now on day 3, the child has become lethargic and he has some dehydration. Clinically, it looks like an influenza-like illness, and this child is now admitted to the hospital. So let me start with Mukesh. Mukesh, when we say ILI, what is the differential diagnosis here? What are the other diseases that we have in mind?
So with this kind of an acute presentation, the first thing we think of is an infective disease.
Okay.
And among the infections, if you think of viral, bacterial, and other infections, I think with this kind of a cough, cold, fever, the commonest is a viral infection. And among the common viruses that you see in the first 2 years of life, it includes rhinovirus, RSV, influenza, parainfluenza, adeno, human metapneumovirus. So
any respiratory viruses could behave like this.
Right.
Yeah. Dr. Anil, is there any way of distinguishing non-flu RTIs from flu RTIs clinically?
Yes, sir. There will be few telltale signs which we can pick up. But usually if they're coming to us on day 1, day 2, it becomes really difficult to differentiate. But if we look at, there will be some pointers. So if we start from our very small babies that we see in the OPD, we start seeing a rhinoviral infection typically presents in small babies. So it's a localized infection. They come with lots of nasal block, lots of watery nasal discharge, and little bit of systemic symptoms may be there, like a mild fever-like illness, little irritability and all, which is very, very typical of a rhinoviral illness in a small children. So if we go for a flu, that is influenza group of viruses, the onset is very sudden. So they presented to us with very high grade fevers, usually of 1 or 2 days, severe headache, body pain. Little older children are able to complain of severe headache, body pain. Also, they do complain to us about this severe sore throat on day 2, day 3. They come to us
So
and
in short, it's a very systemic severe disease as opposed to the other viruses, which may have a little
right,
milder course and not so many systemic symptoms. Now, just one
right.
more question is that we've had a lot of dengue in the last monsoon. Can sometimes dengue also be confused with influenza in the beginning? What do you think, Mukesh?
Dengue one, yes, sir.
Yeah. Or either of you, please. Anyone.
Yeah, dengue also presents to us on day 1 with severe high-grade fever, body pain, headache, what we typically call as a breakbone fever. So on day 1, day 2, sometimes even dengue we have seen coming with a conjunctival injection also, like red eyes and severe body ache. So on day 1, day 2, it becomes little difficult to differentiate between the dengue from the flu viruses also.
So when there are no respiratory symptoms initially, I think
Exactly,
it
Prakash. I
can be
think,
difficult to. Yeah.
yeah. So Prakash, generally dengue will come with fever without focus. Okay, there may be congested eyes, but as you rightly said, by and large, respiratory symptoms are conspicuous by their absence. That is the
Fine.
first clinical clue that we have that this
Yes.
may be either dengue or, of course, malaria, which is again re-emerging.
Yeah. So if the child has got a lot of rhinorrhea, cough, it's unlikely dengue. But we do see dengue was thought to be a non-catarrhal disease, but that's no longer very true. So Mukesh, when a child comes to you with the ILI, what are the red flag signs that make you feel okay? Now I should treat him much more. I must upfront start a medicine, or he may worsen. So what are the red flag signs in such a child?
So
And
Prakash,
how do you distinguish
red
between them?
flag, when you look
Yeah.
at red flag signs, you're looking at signs which push you into number one, investigating the child, number two, starting empiric therapy, and number three, hospitalizing the child. So
Right.
red flag signs would be child is having very high fever, child is not well in the interfebrile period, if a small baby is not accepting feeds, not sleeping in the night, if so there are any of these signs, and if you examine the child, you look at the vital parameters, you find disproportionate tachypnea, you find maybe a pulse oximeter, a sat saturation which is not as good as you would expect, a 98 99 saturation. So
Right.
all these signs would give you a clue that something more serious is happening and that you need to push up your management strategies.
So, Dr. Anil, how do you clinically distinguish between severe flu versus non-severe flu?
Yes, sir. When we are talking about severe flu, typically in the influenza-like illness, we are talking about moderately sick category B and a category C kind of illness. So severe, non-severe is if the child is active in the interfebrile period, is able to feed on his own, his or her own. These are all milder cases. These are all non-severe. If the child is inactive, becoming lethargic, unable to feed, and like what sir told, child starts developing other systemic complication like as respiratory symptoms, we start seeing that the child becomes tachypnic, the cough becomes incessant, unable to feed. All these are signs of complexity, or the it is going into category C. So
So
these are the red
WHO
flags.
guidelines have said that severe flu is has symptoms like sepsis, shock, pneumonia, ARDS. All the
Yes,
symptoms, whatever symptoms you mentioned, will actually lead up to the description of the above. So
yes,
these severe flus requires hospitalization. Sometimes they may even
in the
require
ICU itself.
mechanical
Prakash,
ventilation, etc.
Prakash, one more red flag sign is
Uh,
the presence of an underlying illness, be it
yes.
a chronic lung disease like a bronchopulmonary
Yeah,
dysplasia.
we will come to the risk factors in a minute, Mukesh, where you can just elaborate a little more on this.
Okay.
My question here was that when a child with a typical respiratory infection becomes lethargic, to me, that is one of the indications that this could be influenza and that requires treatment. So now I'll just ask both of you, how will you treat this child? Will you first send a swab for influenza or will you straight away start Oseltamivir? Maybe Mukesh, you can take this first.
So I think it also depends on the kind of epidemiology that is happening. So it's very crucial for you to keep your eyes and ears open and see what is happening in the community. So if I have an influenza epidemic that is happening, where every child right, left, and center is coming with influenza, especially for my hospitalized children, because Prakash, you will never start investigating outpatient children
Yes.
for a viral etiology initially. the first clue you would get of an epidemic is from your hospitalized and your
I was
ICU
talking
picture.
of this child who was admitted because it looked like a severe illness. So would you send us a swab for flu here?
Yeah, definitely, because this
So
would qualify as a upfront child for both sending a flu swab and even without waiting for the swab to start empiric oseltamivir.
absolutely. So this is a case for empiric where the child is lethargic, where the chances of flu are very high, and epidemiologically in the neighborhood, it fits into that. Would you agree, Dr. Anil?
Yes, sir. Anybody who deserves to be hospitalized and either in the ward or in the ICU, our protocol has been we go ahead and, like what sir told, empirically start them on oseltamivir and also get the swab test done.
Right.
Only financially, if they're even for the admitted patients, sometimes if there are financial concerns, sometimes we just treat empirically pending the swab test results.
Fair enough,
So
Anil.
whenever
I'm
possible,
with you
you
on
can
that.
send the flu swab and start oseltamivir upfront without waiting for the PCR report. I think that we are on the same page for that here, right?
Absolutely.
Okay. Yeah. So let me take one more case. This is a little tweak of the first case. This is 18-month-old Shlok who came with history of a typical febrile seizure. He came to the clinic with fever of day 2, and that time he was very active. And since he had recovered completely from the seizure, he was sent home on symptomatic treatment. He continued to have intermittent high-grade fever, but was active interfebrile. Then this was in the morning. In the evening, he gets another short-lasting febrile seizure, but this time he was admitted. Now, this is a child now on fever day 3. It is the flu season. This child is getting intermittent high-grade fever, but on fever basis alone, he never required admission. He required admission for the convulsion. Now, it's a tricky question for the clinician. Should I give oseltamivir here or should I wait? I would like Dr. Anil to take this first.
Yes, sir. Going by my just very recent experience, I think I'll go ahead and start this child on empirical oseltamivir. Even though the child was active and we are admitting the child mainly for the recurrence of febrile seizure, because oseltamivir is one drug which will prevent the progression of illness.
Right.
So any CNS kind of a complications. Just I'm coming out over the last 15 days, I've seen the CNS complications of acute necrotizing encephalopathy also. What
Right.
started as a febrile illness, which was not treated, 2 days started with a febrile seizure, then went into status epilepticus, didn't regain sensorium, went into coma, and then when we did the MRI, typically the bilateral thalami was lighting up with a lot of edema.
Point is taken that flu is not only a respiratory disease, but we are worried about CNS complications, and that will
Complications and
to start
progression we need to stop.
oseltamivir right
Yes.
away. Mukesh, your perspective before we move on?
Yeah, this child is 18-month-old and he has come with another seizure, but I assume that he's hemodynamically stable.
Is hemodynamically stable.
And though we know that flu can come with non-respiratory symptoms are a more common presentation in the smaller infant. This child is about 18 months old. So when I hospitalize this child, my first thought would actually not be influenza. And I would probably not start this child on oseltamivir. I would probably wait for the initial investigations to come in before I put this child on empiric oseltamivir.
So the difference is that Dr. Anil would feel that better to start upfront, and you would say that wait, send a PCR and then start. Is that right? I mean, send the PCR, wait for the report and then start.
Yeah, definitely. I would wait because the child is hemodynamically stable, though he's had 2 seizures.
Yeah.
And so I would work him up.
So I think this is a little gray area, but personally, I would also start oseltamivir here because, as Dr. Anil said, there is a CNS issue. And of course, while this CNS issue was clearly not encephalopathy, I would say that it's on the balance of thing, I would start oseltamivir and behave exactly like the first patient. But I think this is a little gray area where we have...
Prakash,
ongoing epidemic, I think we should go ahead and start, sir.
Right. In an epidemic...
Prakash, what all will you start in this patient empirically before investigations come in?
No, I would not start an antibiotic here at all because this looks like a viral illness. But I would definitely give him supportive treatment. Maybe I would give him clobazam and definitely start oseltamivir with the idea that I might stop it if the PCR is negative. But I would not.
I am seeing a lot of malaria also, both falciparum and vivax in my area now.
Right.
In the absence of
malaria, to start empirical treatment, I think it's probably. I mean, there's no justification right now, and we could wait for a few hours, right?
Yeah.
Okay. So now this was the this was the real peculiar report when this child's test was done. It was, I'm sure you can't read it. It's not very clear, but what I can read it for you is that real-time PCR detected influenza A, but it was neither H3N2 nor H1N1. It was a different subtype. This is one of those unusual things. Most of them are H3N2 or H1N1, but still you are getting some other non-specific subtypes also. So now to come back to this patient, that he did not have a second seizure, but he was active when you saw him. The intake is not normal, but intake is okay, and he's passing a good amount of urine. So I want to now come on to the other perspective. Is there any indication for oseltamivir in an OPD patient? And when is there an indication for oseltamivir in an OPD patient? So I think first, Dr. Mukesh, you can tell me, and then we'll get Dr. Anil to come through.
So if there is a clear-cut epidemic on, and your epidemiological data tells you that influenza is, so you'll have two situations actually. One, when there is an influenza epidemic that is going on, and the second is when there is no influenza epidemic
I'm
going
talking of a child when the epidemic is on,
on.
like
Yeah.
in current days.
So in this kind of a child, what is crucial is the timing of starting the drug. We all know that it works best if initiated in the first 48 hours. So there's a narrow window for us to minimize the complications and have the best effect with oseltamivir. So my threshold for starting this drug would be low in certain indications. As I told you earlier, in case the child is having a high risk, be it a
Yes.
lung disease, be it a
Yes.
congenital heart with
So
left
you
right
can now
shunt.
go on to tell me which are the high-risk children. Yeah.
Yes, so be it the preterm child who's been in the NICU, he has a chronic lung disease, be it a cardiac disease with a left to right shunt with increased pulmonary blood flow, be it a nephrotic syndrome, be it a patient with a hemolytic anemia like a sickle cell, be it an IDM, be it a primary immunodeficiency, be it a secondary immunodeficiency like HIV. So
So any immunocompromised child or a child with a comorbidity, your threshold for oseltamivir will be very low. Is that right?
that's right.
Yeah. Dr. Anil, would you add to this? Anything you would like to say?
Yes, sir. Any other high-risk person in the family, for example, we have
Absolutely.
some grandparent who is on chemotherapy, someone is diabetic, someone is immunosuppressed for any other reason,
Right,
and
right.
the high risk, someone who is like less than 2 year old in the family. I think it's better to go ahead and treat the case even on OPD basis. So when we are taking it, when we are deciding it, I think we should consider all the other factors also to protect the family as such. We can start them on oseltamivir.
So to sum up, OPD indications for oseltamivir, yes, they depend on the patient's condition. They depend on the situation in the neighborhood of the amount of epidemic, that whether flu epidemic is going on. But two things will dictate your treatment a lot. One is if there is any comorbidity. Is the child, I'll just give you a list of comorbidities. And second, as Dr. Anil pointed out, is this child going to infect a vulnerable senior citizen or a vulnerable immunocompromised patient at home? Then yes, I should give him oseltamivir to prevent that from happening. So the high-risk children are children with high-risk contacts, are those who have a household contact who is less than 6 months of age or is at high risk for complications. This requires this is from up to date. So which are the categories which are high risk groups? As Mukesh already said, chronic lung disease like asthma, cystic fibrosis, BPD, cardiovascular disease, kidney disease like chronic kidney disease, hepatic disease like cirrhosis, metabolic disorders like diabetes mellitus, cerebral palsy, epilepsy, neuromuscular disorders, extreme obesity. Just remember, a very obese child or adolescent may be more vulnerable and requires oseltamivir more likely upfront. And an immunosuppressed child, a child who is on steroids or an immunosuppressant. So any of these children who are there will require oseltamivir much more much more strongly than a child who does not have this. And of course, the children who have high risk contacts at home, as we already discussed. So now I'll just get both the panelists. Mukesh, in your practice, how often do you give oseltamivir without actually proving the diagnosis?
Again, 160, the decision to use oseltamivir in a high-risk patient is actually very easy. But the question is, in the non-high-risk patient, how do you use it?
Yeah.
Because as we both know that almost 50% of all hospitalizations due to influenza as well as deaths due to influenza occur in patients who have no high risk. So you have a normal child with no high risk gets influenza, gets hospitalized, and you can even lose him or he goes into the ICU. So I think that is the most difficult decision as to in whom would you use Oseltamivir, which actually is very difficult to answer.
Right. I think it's a lot depends on the situation at that time. Probably not a very fair question to answer because there is a lot of gray areas here. What about you, Dr. Anil? What would you say?
Yes, sir. Whenever there is an epidemic going on, and like for example, today I had a patient, I think rightly, who came to us and told already day 5, day 6, the elder sibling is getting better. They had got a swab test done, who was not started on Oseltamivir because he was getting better on his own. But now they came with a 2-year-old child who was sick. Day 1, spiking 102, 103 fever, was little delirious. This child, I didn't test. I went ahead and started Oseltamivir.
I
So
think a
for
lot depends on
high-risk
the
patients,
clinical condition. Yeah.
high-risk patients, we go ahead and start Oseltamivir even without testing them.
Fine. So, Mukesh, if there is a case with a non-respiratory symptom and you still suspect flu, have you had such cases? And there, would you start Oseltamivir?
Yeah, so if you look at world literature, it talks about how the smaller infant, especially below 3 months, may come only with fever without respiratory symptoms. But I'm sure all of us have, even in older patients, it may happen that it may be a non-respiratory onset, and then through the clinical course, respiratory symptoms develop. So yes, you can have influenza without respiratory symptoms or without striking respiratory symptoms, and it could still be influenza, definitely.
So yes, there can be situation where a child may come only with, and as Dr. Anil pointed out, a child can come with CNS problems and he can come with encephalopathy, and we'll be discussing one such case. But a child may also come with, have you seen a child who comes only with intestinal symptoms like a diarrhea and it turns out to be influenza?
Yes, sir.
Yeah, that was more common with adenovirus.
Yes.
And less with influenza. But yes, we always teach our students, that when you have multiple mucosal involvement, you think of a virus. So I think with virtually any virus, you can have symptoms which affect multiple systems, and that can mislead us.
So the only problem here is that if you want to prove influenza, you have to do it by a nasopharyngeal PCR. You don't have a CNS equivalent to proving influenza from the CSF. The BioFire does not have that. The other thing is that if you can't prove it from the stools, like in a stools, you can show adenovirus, but you cannot show influenza. So influenza will have to be picked up from the nasopharynx, and then you will have to ascribe the other symptoms to influenza. I think that is the way it would work. Now, do you both always do a flu swab when you are giving Oseltamivir, either before or after therapy, or you don't do it always?
No, sir. No, not all the time. Anybody who is sick enough to get admitted in the ward or in the ICU will get a swab test done. But someone where we decide to treat based on the epidemiology and someone else in the family is already positive, we don't really need to do a test. And of course, after therapy, rarely we do. It is not recommended that we do any swab testing after therapy.
That was wrongly phrased. After starting therapy, not completing. Suppose you have started a patient's therapy and you want to make sure that that it was flu at all. You started, you've just given the first dose, and would you then do a swab to find out whether I need to continue the dose, or now that you have started, you will continue?
Not for a OPD patient, sir. For a OPD patient, I think if things are fine, I wouldn't do a swab.
So PCR is not mandatory in an OPD patient. You're probably much more likely to do it in a hospitalized patient.
Hospitalized patient, I would do, but not for a OPD kind of patient.
So now I'm giving you a situation where you have a child admitted with an influenza-like illness. You have sent the nasopharyngeal PCR and you have started Oseltamivir. And surely enough, 24 hours later, your nasopharyngeal PCR comes negative. What would you do, Dr. Mukesh?
So I would probably continue Oseltamivir until I get an alternative secure diagnosis. If I have sent a multiplex PCR, I get another virus, and clearly, which is pathognomonic. See, if I get a rhinovirus, enterovirus, I'm not sure. But if I get a RSV or an adenovirus or a human metapneumovirus, then I'm on slightly more secure ground as to clinching the diagnosis. But until I get an alternative diagnosis, I would continue Oseltamivir.
We'll come to the, Dr. Anil, what would you say?
Yes, sir. If there is no other alternative clinical explanation for this respiratory viral kind of a syndrome, I would continue with
Now,
oseltamivir.
WHO
further.
guidelines say that you can start on suspicion, but if it is negative, you can stop the medicine. This is what the current guidelines are saying. But I think one has to take on a case to case decision on this. Now, as Mukesh was saying, that if I do a respiratory biofire and I find another virus, but respiratory biofire, that is a multiplex PCR, is way more expensive than the flu PCR, maybe twice or thrice the cost. So in most of the hospitals, flu PCR today is bundled with RSV. I don't know whether that happens in your case. What do you have you got that experience, Mukesh and Anil?
Yes, sir. We can ask for either for only for the flu PCR where we check for influenza A, influenza B, and the subtypes,
Correct.
or it comes bundled with RSV and adenovirus. And COVID, of course, COVID is also bundled along with these
So I
things.
think various
We
hospitals are
also-
having various packages. In our hospital, we have flu plus RSV, and many times I've started oseltamivir thinking it is like a flu syndrome, and it flu is negative, RSV is positive. Then I would probably withdraw because I have the pathogen. But as Mukesh rightly said, if you do not have have a possible pathogen, a probable pathogen, the best is to continue.
And
Uh,
also, Prakash,
yeah.
it's you can get adeno, you can get human metapneumo, you can get RSV, you can give parainfluenza. So if
Yes.
you're doing a influenza single detection, I would mean at least in the serious patient in the ICU,
Mhm.
I would prefer a extended panel.
But even
Because
then, the costs of a biofire are probably three times the costs of just a flu swab. So sometimes you have to be practical and send only the limited test. I mean, that's what we have to do. Hello, Mukesh.
yeah, fair enough.
Yeah. Okay. So now this is a table from up to date about the choice of antiviral disease therapy for children with suspected or confirmed influenza, and you will see that most of the time, up to five, it is only oseltamivir, and otherwise they talk of baloxavir. Baloxavir is not available in our country, so the only agent of choice is oseltamivir, which is studied in so many clinical situations. We have great experience with this agent, and it is actually even in the last 26 years that it has been used. We hardly have any evidence of resistance developing. Maybe there may be a few emergence of escape mutant, but it's not very common. So now let me take another case. I have this mother who's breastfeeding and she has got symptoms of moderate influenza. Her physician wants to start oseltamivir. So she calls you, her pediatrician, and says, Doc, is it safe for my baby if I take oseltamivir? I'm breastfeeding. Mukesh, your take on this?
Yeah, I think we have indications for using this drug even in very small babies, including preterm babies. And since the indication is very clear, the baby is breastfeeding, I assume the baby is just a few months old.
No, absolutely. First month baby. I should have specified that. Yes.
Yeah, so clearly, not only is it important for the mother, more importantly for the baby to not contract influenza. So I would tell her that you go ahead and start the drug. It's absolutely fine for the baby. No issues at all.
Now, here again, I will play the devil's advocate and say that the mother is having influenza. The baby is 1 month old and he is definitely a high risk baby. Would you start simultaneously prophylaxis for the baby also?
That's a difficult call. But yes, probably because it's such a small baby, and we know
Right.
that influenza in babies below 2 years is the high risk. So I remember that initially when the guidelines came, even IIP recommended vaccination below 2 years because this category is such a high risk for
Yeah.
life-threatening influenza.
Vaccine
So
we will come to, but this baby is now one or 2 months old, and the mother is breastfeeding, and you have said go ahead with oseltamivir. Now, do I need to protect the baby also with prophylactic oseltamivir is my question. Maybe Anil, what is your perspective?
So, according to literature, prophylaxis below the age of 3 months is not advocated. I think
Okay.
the it's not licensed for use below three months of age for prophylaxis. But when it comes to treatment, Babies as young as for 14 days, 2 weeks and above is advocated that we go ahead and
In a
start them
severe
on the treatment.
situation, surely you will give Oseltamivir, which my next question was, what is the youngest age to give Oseltamivir? And it is 3 months. But in a baby who is sick or when there is a life-threatening situation, there is no young age. At any age, you can give Oseltamivir. But as you rightly said, I would probably not give prophylaxis to a very tiny baby because that indication is not there. But if the baby is symptomatic, I would definitely not have an age barrier. Is that right?
Yes, sir. Yes.
Prakash, given the excellent safety profile and conspicuous lack of side effects, my threshold for starting it even for prophylaxis would be much lower.
Right. But there is a recommendation that prophylaxis. So for now, if you see this chart from up to date again, below 3 months, term infants, prophylaxis is not recommended except in critical situations.
You have not told me how many months old the baby was.
Yeah, I told you 2 months now, 1 or 2 months.
Okay.
Yeah. I said that was my bad, but I then mentioned it was 2 months. Right. So it's a child below 3 months. It is 3 milligram per kilogram per dose orally, but prophylaxis is not recommended except in critical situations, but treatment is recommended. But again, 0 to 3 months, they have said prophylaxis is not recommended except in critical situations. So don't use the drug unless there is really a critical situation. But above that, of course, prophylaxis, nowhere in young children they recommend, as far as possible, chronological age 9 months through 9 to 11 months, they say you can use prophylaxis. So in younger children, prophylaxis is not the standard of care unless you really feel that the child is really sick, then you have to use it even before you prove flu. And of course, as far as therapeutics is concerned, it can be given even to preterm babies less than 28 weeks, though they say consultation with a specialist is recommended. But 28 through 37 weeks, this drug, the doses are a little different. They are lesser than usual, please note, but it is recommended even for a preterm baby. That is the safety profile of Oseltamivir, as Mukesh was pointing out. So let's take now one more case. 11-year-old boy with fever, vomiting, cough, cold, and he has come with altered sensorium for 2 days. Clinically looks like some sort of a febrile encephalitis. X-ray done showed right lung haziness. Child was intubated in the ER and shifted to the PICU for further management. Lumbar puncture done. CSF was normal. He was started IV antibiotics, IV antiviral. Now, when I say antiviral, of course, I mean that he was started on herpes
Acyclovir.
acyclovir and other symptomatic treatment. Labs on admission were quite unremarkable, and the nasopharyngeal multiplex PCR detected influenza A and H3, but the CSF meningitis panel was negative. So please comment on this case, Dr. Mukesh.
So fair enough. I think you have the CSF panel negative. And as you had mentioned a little while earlier, your panel does not contain influenza. And knowing full well that influenza can cause encephalitis, encephalopathy, acute influenza encephalopathy, I think you have a diagnosis here. I assume that the other investigations are normal. So your diagnosis is acute influenza encephalopathy.
So it's a surrogate diagnosis, but I think you're justified because, as we know, none of the approved panels contain influenza virus. The CSF BioFire does not contain influenza virus, unfortunately. So we cannot prove that it is the thing. And yeah, this is the X-ray of the child. So Dr. Anil, your comments here?
Yes, sir. There is no direct viral invasion of the CNS. Usually, this is immune-mediated kind of a situation where there is a IL-6 mediated kind of a response which acts on the CNS and causes encephalopathy, and sometimes the child becomes deeply comatose, and some necrotizing changes also can come in. So, of course, that's the reason why when we do a lumbar puncture in these kind of cases, the CNS won't show any cellular kind of a response. We'll see that cells are normal,
Right.
but we have seen that the IL-6 and other mediators are hugely elevated in such children and will require a little bit of immunomodulation also for necrotizing encephalitis at some
I
point.
think the take-home message here is when the child comes with encephalopathy in the flu season, think of flu as the cause, send a nasopharyngeal PCR and probably cover him with Oseltamivir till you get the report. Now, this child, the neurologist opined as viral encephalitis. The baby continued to have fever spikes, and then he started having symptoms of acute kidney injury. So, and therefore we stopped acyclovir by then. And do you know any incidence of AKI caused by the influenza virus, Dr. Anil?
Yes, sir. Because it's a multi-system progressive disorder, we have seen that there is little bit of kidney injury. When it progresses, it can involve the kidneys, it can involve the liver to cause lots of transaminitis and rising liver enzymes it can cause. In the CNS, it causes progressive encephalopathy. So influenza is a classical multi-system involvement that we see. Probably starts with our respiratory system, and then it can cause other spread to the other systems also. So whenever we see a child who's becoming sick like this into category C in the ICU, intubated, renal injury and a liver injury, influenza is again in this epidemic season is there in the top of the list.
So, Mukesh, this child came to you on day 5 or day 4, transferred from a peripheral hospital. They had not thought of influenza as the cause at all. So now he has come to you on day 5 or day 6, and he's comatose. The CNS shows viral encephalitis, but your nasopharyngeal swab had been sent and it showed influenza. So upfront, would you put this child on Oseltamivir, or is it too late?
I know why this question is coming, Prakash, because we just discussed a little while earlier the best results are in the first 48 hours,
Yes.
after which the efficacy is suspect. So if it's a stable, improving child and you pick up influenza on the 4th, 5th day, you would not. But in an unstable child who's critical, whom we have very little to offer, definitely you would start influenza treatment and you would start Oseltamivir in this child. Also keeping in mind that new clinical symptoms are still emerging and you're wondering whether the virus is still replicating, though data says that the first 48 to 72 hours is the crucial part. But I would still give this child Oseltamivir to give him the benefit of doubt.
So the take-home message is it is never too late to give Oseltamivir, even if they say in the first 48 hours. But if the child is sick in the flu season, for whatever the benefits are there, we will still give, though the ideal time is early, but you can still give it. And this is what even up-to-date and the standard references are advising, that Oseltamivir may be administered more than 48 hours after symptom onset, particularly in hospitalized children, those with serious complications or progressive disease, and those at high risk of complications. So there is never an upper limit. You can give it if the child needs. So this is the WHO algorithm for influenza. Suspected or confirmed influenza. Is it severe? Give Oseltamivir. If it is he at high risk of progression to severe illness, and we mention all the risk factors, then also they say give Bolaxavir, but in India it is Oseltamivir. And if neither of it is there, it's not severe, it is no high risk, then no antiviral. And influenza prophylaxis, they have said, person with no symptoms of influenza, if he is exposed, if he's at high risk, we will give prophylaxis. If it's a zoonotic influenza virus, unknown virus, we'll still give prophylaxis. But in a normal person, non-immunocompromised, we will not give. Let's take one more case. This is a 6-year-old boy with an influenza-like illness. 2 days, 3 days, up to on day 3, he's still having high-grade fever. And now I propose that we will start Oseltamivir. And the mother protests, but doc, he has received the flu vaccine. Dr. Mukesh and Dr. Anil, one by one, I would like your reaction in this case.
Sir, definitely this is a common scenario that we come across. Parents keep a tab on this because we would have counseled them telling that by taking flu vaccine, we are protecting against the seasonal flu virus. That's what we would have counseled against. But I think we should take one extra minute and counsel them. At best, the flu vaccine is 70% it's efficacious in preventing the flu. And it
Absolutely.
prevents against the seriousness of the flu. It doesn't prevent the flu. It prevents against the seriousness.
No vaccine is 100%. Flu vaccine is not. So, Mukesh, what do you have to add to this?
Absolutely. The vaccine is only 60% efficacious, the average. Also, by the time the vaccine reaches us, we are not even sure it's covering adequate strains or not. Also, sometimes they claim they've taken the flu shot and it's probably last year or year before that. And it's not so-called the annual flu shot. So, I think the bottom line is, even after vaccination, child can get
flu vaccine has not changed the story in any way.
Yeah, you don't need, yes, you need to treat, absolutely.
And do you do flu swab first? I think you already answered that. You may not do it in an OPD patient. So in short, treatment should be initiated regardless of whether the patient has received a seasonal influenza vaccine. Do not delay awaiting the results of viral testing. A rapid diagnostic test for influenza. Now, a rapid diagnostic test is not actually a PCR test. So positive test for influenza does not mean that there is no other infection. But suppose I get a negative PCR, what is your experience? Are we reasonably sure that it is not flu, or even a PCR can miss a flu? Both of you.
Sir, I'll take it. The sensitivity of a well-done PCR study, if you are taking a good dosage of nasopharyngeal swab, the sensitivity is almost 95%. So
Correct.
almost in 95% of cases, we will be able to pick up a flu if there is a flu. But sometimes the swabs are not very well taken. They're taken from the anterior nasopharynx and without not much secretion. That time the sensitivity comes down to as low as 60%. So
Right.
we should always correlate with the symptomatology, our clinical acumen, and if there is no other alternative diagnosis, then the possibility of it being flu is more
So a
likely.
well-taken swab will have a 95% sensitivity and probably 100% specificity. Would you agree?
Yes, sir.
Yeah.
Prakash, also,
uh,
it depends on if the swab is taken in the first 48 hours or a little later. Because as the timing of the swab from onset of symptoms increases, the yield drops.
The yield drops.
Viral shedding drops.
Yeah. So now all of us have been using a great deal of oseltamivir in practice, and there are going to be adverse reactions. So I'd like both of you to share what in your experience are the adverse reactions of oseltamivir. And Mukesh, you could begin this, please.
Actually, in actual practice, zero. I have found it's extremely well tolerated and it's accepted very easily. And I have clinically found no side effects that warrant any kind of warning or withdrawal of the drug.
What about Dr. Anil?
Yes, sir. They cause very, very mild. Even if there is mild nausea and sometimes vomiting may be reported. In my practice, I don't start them on a PPI as a must for everyone. Only in case they come back to us on day 2, day 3 after starting oseltamivir and they're complaining of it, then probably a PPI may be started.
So there are some people who start PPI with oseltamivir, but actually that is not the standard of care. I agree with both of you that the side effects of oseltamivir are exaggerated. There are hardly any side effects in my practice too. But yes, there are kids who develop GERD-like symptoms, and in those you will give the appropriate treatment. So then there is an adverse effects in less than 1%. In Japan, particularly, they found neuropsychiatric effects. Have you either of you seen these?
No, sir.
Not really. No.
Yeah. So in Japan, they found neuropsychiatric, but the causality has not been established. And now they say that some of the neuropsychiatric events may be related to the flu virus infection and not the treatment. So one more common question which mothers ask you, so let me ask both of you, is that this is a child, my child has got influenza-like illness. Doctor, when can I send him to school? Because mothers don't have any patience and the kid also usually demands to go to school early. So let me see your individual perspectives. Dr. Anil first. Hello? Hello? Hello?
Yeah, the period. Hello?
I couldn't hear you. Yeah, sorry. Yeah. Dr. Anil. Dr. Mukesh, can you hear me?
Yeah, I can hear you.
Yeah, maybe I think Anil's sound is not there. Maybe you could take it up for now.
Yeah, so our concern is of the child spreading the influenza bug to his classmates.
Correct.
So I think, see, the maximum viral shedding occurs in the first 48 hours, but it continues up to 5 days. So in an epidemic, I think you would strongly recommend the child does not go back to school in the first few days, even though he is now okay, his fever has gone. I think 5 days from onset of symptoms is what he should remain at home for.
Right.
For him to recover, and more importantly, for him not to spread the virus in the community.
But parents usually do not follow this advice. So what CDC has said is that the child should stay at home until 24 hours after the fever has resolved without any antibiotics. So by and large, you are into the 4th or 5th day. But again, as you said, the disease gets transferred more easily. So tell me one thing, whether the child received oseltamivir, does it shorten the period that he needs to stay at home in your experience?
See, oseltamivir reduces the duration of symptoms by 1 day. I'm sure that it's an antiviral drug, it will reduce the replication. So I'm sure the shedding would be less and for a shorter duration. So the child who has received oseltamivir should go to school earlier than the child who has not received oseltamivir.
I think that makes a lot of sense. Dr. Anil, can you hear me? Dr. Anil?
Yes, sir. Yes, sir.
Yeah.
Yes, sir.
Yeah.
So the period of infectivity, as per the literature, is 1 day before the onset of symptoms to up to 7 days also. Like what sir told, 5 days seems to be a reasonable protocol, and 24 hours of fever-free period and that feeling well-being of 24 hours, probably we can take it as a good indication to send the children back to the daycare or the schools.
But this recommendation applies as per CDC, irrespective of whether the child received antiviral. So if he has received antiviral and has become afebrile on day 2, then by this definition, on day 3, he can go to school because he's 24 hours without antipyretics. So I think oseltamivir may shorten that duration because the viral shedding will get reduced to that extent. So one more common thing is that many times in a child in a season where there are many fever cases, we tend to use antibiotics very, very frequently. So do you feel that using oseltamivir has helped in antimicrobial stewardship, Mukesh?
Yes, I guess it has, because fortunately during the influenza epidemic, the temptation to use an antibiotic would go down, I think, among clinicians.
Right.
You know, let's face it, in office practice, the temptation to offer something to the child is a little strong.
Yes.
And we may err on the side of writing an antibiotic when you're not offering anything concrete in terms of treatment and cure. So I think when I have a child who's in a flu epidemic, who's having flu-like symptoms, and I write an oseltamivir prescription, the temptation to use an antibiotic becomes virtually zero in that case. So yeah,
Right.
I think Prakash, it does help in antimicrobial stewardship in that
Dr.
way.
Anil, do you think that helps? Has it helped
Yes,
you?
sir. Yes, sir.
Yeah.
Even the swab testing probably gives us great confidence not to use any
Not to use
unnecessary
antibiotic.
antibiotic.
So are
If
we
someone-
using oseltamivir, overusing it by? Sometimes I wonder if do you feel that is happening in the community?
Yes,
No,
sir. We are erring on both sides. Many a times we loosely do prescribe, and sometimes we kind of hold back also. I think we
Right.
should take the middle path, which is the most difficult.
Yeah.
Sometimes it does happen, sir. Sometimes over prescription is happening, sometimes under prescription is happening. So I
Yeah.
think we need to be a little balanced in our approach here.
Excellent. We are actually running out of time, so I'll now be a little faster. Now, I'll just give an example of this 10-year-old boy. I want to ask you, this child had come to me, presentation with high 2 days of fever with rigors. My resident said that this child, they saw the child and said he has tonsillitis. So I'll be giving an antibiotic. This was in the OPD. But this child had tonsillar crypts and really no follicular tonsillitis. And at the parents' insistence, we did a test from the nasopharynx on an OPD basis, and the test detected influenza A. So here we could be very confident and avoid an antibiotic, though it was looking very much like a tonsillitis. Let me take one more case. This is an 11-year-old girl with fever since 2 days, high grade, not associated with chills or rigors. And she came to us with difficulty in breathing, aggravated since 1 day, associated with post-tussive vomiting, and the child had bronchospasm. Now, interestingly, this child was admitted last month elsewhere, and the swab had influenza A, and she was treated with oseltamivir. So this child was quite sick. We gave her HFNC support and then injection ceftriaxone, then Dexa, and she was empirically started on Fluvir again, oseltamivir, and we had also sent a swab again, and this was the treatment given. Now, my question is that if the child had influenza A last month, are we justified in giving her treatment for oseltamivir here? A quick yes or no from both of you.
Yes, Prakash, you're justified, because I
yeah.
think epidemiology has shown that you may get multiple influenza attacks
Correct.
from various strains of the virus.
So you treat the patient on its own merit. This is a patient who independently requires oseltamivir. It is a flu season and the child is sick. So I think we would give. Curiously, this child's swab showed influenza B this time with RSV. So the moral of the story is, given last month, if the child clinically fits in now, we would probably go in for the treatment purely on merits. Dr. Anil, anything to add in such a case?
Yes, sir. Influenza B, yes, but many para-influenza shows positive. We shouldn't be treating that with oseltamivir.
So this was the X-ray, and I'll come to that. So during oseltamivir therapy, Sometimes we are also prompted to use antibiotics. Can you just tell me when, very quickly, when would you use antibiotics in oseltamivir therapy?
If there is a localizing symptom like a lobar kind of an involvement, unilateral kind of an involvement,
Correct.
or we start seeing a bacterial evidence with our lab
So
parameters
maybe an
also.
increasing CRP, neutrophilia, persistent fever, and as you said, a
And
lobar
even
involvement.
after 48 hours of oseltamivir usage, there is no clinical response. That's an
Yeah.
indication to go ahead on with antibiotics.
So sometimes you need to add. Okay, so now quick one-liner from each of you. We have to be really fast now. Oseltamivir prophylaxis, parents of an admitted child, Mukesh, yes or no?
No, unless high risk.
Okay. Grandparents of the discharged child, Dr. Anil?
Yes, sir.
Yes. Younger sibling of the influenza patient, one child is admitted. The younger sibling, does it deserve prophylaxis?
Less than 2 years, yes, sir.
All right. And very small younger sibling, no.
And
Yes, sir.
grandparents also more than 65, no? They might be like,
Correct.
you might
Yes,
have a
sir.
50-year-old grandparent.
Okay,
Young
sir.
grandparents, no. Grandparents with any comorbidities,
And
yes.
with any comorbidity, yeah. So
Fair enough.
post-exposure is indicated only for individuals who have an extremely high risk of hospitalization and should not be arbitrarily expanded. So now I had a child with croup, a 3-month-old child, and as Dr. Anil said, we did a thing and it turned out to be para-influenza. So should I give oseltamivir, yes or no?
No.
No.
No,
Both of
sir.
you? Yeah. So just because there is influenza in the name, do not give oseltamivir. So what are the contraindications to oseltamivir? Are there any contraindications in practice? Maybe Mukesh, you could take some of these.
No, I think your indication is so strong for a serious illness that there is, just like in a rabies vaccine, there is no contraindication. I think the
Right.
same applies to oseltamivir.
Okay. So Dr. Anil, anything to add?
Nothing, sir. Only documented hypersensitivity we avoid, otherwise no, which is very, very rare even in the literature.
So basically, they are saying contraindications to oral or enteric treatment like malabsorption, delayed gastric emptying, GI bleeding. These are relative contraindications. But in our country, where other options are not there, I don't think even these can be contraindications. Would you give oseltamivir to the pregnant mother?
Yes, sir.
Yes. So pregnant woman can be offered when the potential benefits of using the drug are more likely than the risk of harm, and it is safe during pregnancy with no malformations or neonatal toxicity.
Yeah, Prakash, in pregnancy is a
Huh.
high risk for
High
severe
risk.
influenza.
Correct.
So
Yeah.
that becomes a strong indication, in fact, because we are vaccinating all our mothers for the influenza vaccine.
Yeah,
So that
vaccine is
becomes
allowed,
strong.
but even oseltamivir does not cause fetal malformations to the best of my knowledge, to the best of the reports. So that's why we can give it in pregnancy. Now, is there any kind of compromise of the dose in kidney disease or liver disease, both of you?
We
No.
need to be extremely careful with the kidney disease. Whenever there is a renal insufficiency, we need to be careful with dosing of oseltamivir.
Correct. And is there any time difference between oseltamivir and flu vaccine? Is there any time difference required?
3 days before and 2 weeks later, especially the nasal vaccine should be avoided.
So for live vaccine, there is a problem that you can't give it. So if you're given it 2 weeks back, don't give oseltamivir for 2 weeks, otherwise the effect is gone. And don't give it 48 hours after oseltamivir therapy. As far as inactivated influenza vaccine is there, which is available in our country, there is no contraindication existing. You can give it even during oseltamivir therapy. So I think we have covered a lot of ground, and I'll just make a sum up before we stop this. Oseltamivir is currently the only anti-influenza drug available in our country. It is a very useful drug in treatment and prophylaxis. We should use it timely and wisely, and we should not use it indiscriminately. So I thank my panelists for being very crisp and perfect in their answers so that we could cover a lot of ground in this time. And with this, I will stop sharing my screen.
Excellent job, Prakash.
Thank you, sir. Thank you so much.
Thank you.
Thanks, Dr. Prakash, and thanks, Dr. Adil, Dr. Mukesh. It was a lovely presentation with lovely insights into the disease and the treatment pattern. In fact, some of the questions were really googly, but then you all managed it very well. And thank the marketing and sales force, and thanks IT Nagadevi. Thank you, Samruddhi, and thank you all the doctors who took time in the afternoon session and could attend. Thanks, all of you. See you
Thank you.
soon.
Thank you. Thank
And
you.
we'll log out. We can sign off.
So we will go to the other link in 10 minutes time.
10 minutes.
10
Yes,
minutes.
sir.
Yes, sir.
Okay.
4-10 येऊया सर.
Just for a curiosity, how many people are there?
In the current
Several-
session, sir? 15.
Only? Okay.
Yes, 15 doctors.
Okay.
Okay, sir.